myself. Okay, so good morning, class and Dr. Sashi. So I'll be presenting on hemophilia. Don't mind the spelling mistake. I will change that after. So I'll even enlarge this. So hemophilia, it's defined as disorders of blood clotting, which can lead to serious bleeding. There are 3 types, and these types are determined based on which clotting factor is deficient in them, as we will learn later on in etiology. So you have hemophilia A, B, and C. All of these lead to, all 3 hemophilia lead to impaired secondary hemostasis or plasmatic coagulation that then manifests as increased activated partial thromboplastin time. So etiology, it's an X-linked recessive defect. So it can be either inherited or it can come about as spontaneous mutation. It can also be due to antibody production against the clotting factors. And as mentioned before, the hemophilia, the types are determined based on which clotting factor is deficient. So in hemophilia A, there's a factor 8 deficiency, and this makes up 80% of the cases, so it's the most common. Hemophilia B is a factor 9 deficiency, which makes up 20% of the cases, and hemophilia C, which is the rarest, it's due to factor 11 deficiency, and it's due to autosomal recessive defects, and it's very rare with increased frequency in Ashkenazi Jews population. Note that hemophilia primarily affects the males due to it being an X-linked recessive disease, so it's more likely to show in males, and females are mostly carriers. Clinical features, so patients will present with spontaneous bleeding or delayed onset of bleeding in response to different degrees of trauma. So you can have repeated hemarthrosis or blood in the joint, which can then lead to hemophilia atrophy of the joint. You can also have recurrent hematoma or bruising. There could also be oral mucosal bleeding as well as epistaxis. Note that hemophilia C doesn't typically manifest with spontaneous bleeding and hemarthrosis or deep tissue bleeding due to the fact that its factor 11 is not involved in initial steps of hemostasis, and it's thought to play a more supportive role in blood coagulation via generating of thrombin. So other further sites for symptoms of hemorrhage, CNS patients will present with headaches and stiffness of necks. The GIT will present anemia and hematemesis, and GU is hematuria. Female carriers may show mild symptoms. And also note that petechial bleeding is a more common sign of platelet disorder, but not of coagulation disorder, so therefore it won't show in hemophilia. Also another typo that we'll correct later. So clinical features, the degree of bleeding or severity of hemophilia depends on the residual factor activity levels. So the normal reference range for the activity level is more than 50%. In mild hemophilia, what's it called again? The residual activity levels will be more than 5, less than 50%. In moderate hemophilia, it will be more than or equal to 1%, to about 5%, and in severe hemophilia, it will be less than 1%. So clinical signs as showcased there that you can read. And now for diagnostics, so it's usually patients and family history. Genetic testings can also be done to evaluate the individual risk as well as to identify carriers. Screening prothrombin time will usually be normal. Platelet count should be normal. However, the activated partial thromboplastin time should be prolonged, as mentioned before. So if the APPT is prolonged, then you then go ahead to do a mixed study, and if the mixed study is positive, or if the patient or the family history are strongly positive or suggestive of hemophilia, then you do a quantitative assessment of factor activity levels. And as showed before, those are your that's your normal value and mild, moderate, and severe hemophilia. So treatment is the substitution of clotting factors respective of each type of hemophilia. So for hemophilia A is factor 8, hemophilia B is factor 9, and hemophilia C is factor 11. So mild to moderate, when you only do substitution of clotting factors when it's needed, and in severe, it's lactic. So antifibrinolytic therapy can also be used in addition to factor substitution, and this inhibits the breakdown of clots, therefore reducing the risk of bleeding. Desmopressin, this is indicated in mild hemophilia A. It's used to trigger the release of the VWF factor from endothelial cells, which will therefore increase the factor 8 concentration. Imescumab, I don't know how to pronounce that word, but it's a humanized monoclonal bispecific antibody that reduces the risk of bleeding events. It's indicated in hemophilia A, and its mechanism is that it bridges the activated factor 9 and 10 by binding to both factors, thereby replacing the deficient factor 8. And this activation of factor 8 will restore the clotting cascade. Thank you very much. And that is the end of my presentation. Now I will